मैंने आपको अपना पीपीटी शेयर कर दिया है, चेक कीजिए जीमेल।
Are we on air?
Okay.
Yes, sir.
Okay. Good evening, ladies and gentlemen, and welcome to the 19th episode of Master's Bedside Clinic in Nephrology. I also thank Microlab for supporting this academic exercise. Today, we have got a very important topic that is the viral infections and the kidney. The topic will be introduced by Professor Kher. Let me introduce the speakers for today. We have got Colonel Manu Dogra as the examiner. He is a very dynamic nephrologist from Army Hospital R&R. He is a rounded personality in nephrology with special interest in peritoneal dialysis. He is a very popular teacher there also. The second examiner for today was Professor Shyam Bihari Bansal, but I think he had to leave because of some emergency at home. So his place is being taken by Dr. Amit Mahapatra. He is again a very able and recognized nephrologist and a good teacher. And for this session, we have got an expert, Professor Sanjay Agarwal. Everybody knows that he's the professor and head of nephrology at AIIMS. And he has got special interest in viral infections and kidney. He has got tremendous work on that. So we thought that we should be able to utilize his experience and whatever expert advice he wishes to give on this topic. The students for today are Dr. Pooja. She's a DNB resident from Medanta. And we have got Dr. Vishal. He's a DNB resident from Army Hospital R&R. I'll request Professor Kher to introduce the topic, please.
Well, good evening, ladies and gentlemen. Welcome to this another episode of the current activity on Master Bedside Clinics. And I think it's an important topic. From viral infections can involve kidney, both in the times when patients have chronic kidney disease, and these patients can have viruses as a cause of glomerulonephritis or other diseases. And then once these patients are either pre-dialysis or post-dialysis, they can get viral infections which can have effects elsewhere in the body as well. And then post-transplant also, viruses do involve kidneys, both pathogenically in certain diseases like BK virus, cytomegalovirus. These are very, very common infections post-transplant, and hepatitis B and C and other viruses are also common in patients of chronic kidney disease and especially dialysis. And it is for this reason that Dr. Sanjay Agarwal, who is an expert in the area of especially hepatitis B and C in patients of chronic kidney disease, and he is published fairly well, and he's published also in areas of post-transplant infections as well. And there's a reasonably good data coming from All India Institute of Medical Sciences and from his center. So it would be good to look at an overall effect. So we will have two cases being presented today, and hopefully we should cover during the discussion, most are the aspects related to how viruses impact kidneys as such. So I think without any further ado, let me start with Pooja. Are you starting first?
Yes.
Okay. So Pooja is going to present a case. We'll have 2 cases today, and hopefully should finish within the time frame.
Good evening, respected sirs. I will be presenting the case of Mr. B, who, a 58-year-old male who was a resident from Agra, shopkeeper by occupation and education up to secondary school. He is a known diabetic and hypertensive since 12 to 15 years. And in 2016, he was detected to have chronic kidney disease for the first time. He was provisionally diagnosed as diabetic kidney disease, and this progressed to stage 5 CKD in 2018. In 2018 December, he was initiated on hemodialysis in view of uremic symptoms. He underwent live related donor renal transplant in September 2019, with donor being wife 5/6 mismatch with thymoglobulin as induction agent. He had an uneventful perioperative period and was discharged with a creatinine of 1.1 and was discharged on tacrolimus, MMF and Visilon, and was also given prophylaxis with Septran, Valganciclovir. He was on regular follow-up till June 2020 with a baseline creatinine of 1.2 to 1.3 with no intervening infections or rejection till 2020. Then he became irregular for follow-up but was consulting a local physician. Now, around 2.5 years after transplant, he presented to us with history of loose stools of 2 months duration, easy fatigability of 2 months duration, and a history of weight loss 6 to 7 kgs in a period of 2 months. Loose stools were small quantity, frequent stools, semi-solid to watery in consistency. He had around 4 to 5 episodes per day, and the symptoms aggravated mainly after food intake. It was also associated with periumbilical cramping type of pain. He did not have any blood or mucus in stool and denies any history of vomiting. He also complained of easy fatigability, insidious in onset. Initially, he could do his regular work, but was then fatigued at the end of the day. This gradually progressed to having difficulty carrying out even his work at his shop. There was no history of apparent shortness of breath or cough. He also noticed around 6 to 7 kg weight loss over last 2 months, first noticed in the form of ill-fitting clothes. The weight loss was unintentional and was associated with poor appetite. He denies any history of fever, no history of jaundice or abdominal distension, no history of waxing or waning of symptoms, no history of cough, no history of any lumps in the body. He was admitted with these above complaints at a local hospital around 1 month ago, where he was treated with IV fluids, antibiotics, and other symptomatic treatments. He also gives history that MMF, which he was taking as 360 milligram twice daily, that is 1 tablet twice daily, was also withheld by the doctors that he was showing. He had marginal improvement with these above measures and was discharged on dual immunosuppression, that is tacrolimus and steroids. But again, within 2 weeks, he developed similar complaints and was again taken to the local hospital and again was started on antibiotics. At this time, he was told to have low hemoglobin and deranged renal functions, and hence was brought here for further management. His medication history included tacrolimus 2 milligram twice daily, Visilon 5 milligram once daily. MMF was withheld for around 1 month. He was also on amlodipine 5 milligram once daily. He had received ofloxacin plus ornidazole combination twice daily since the last 4 days, and resicadotril 100 mg twice daily since last 4 days. He was also on insulin for diabetes. Past history included diabetes and hypertension of 12 to 15 years duration, post-renal transplant in 2019. His family history included diabetes and hypertension in father and no history of kidney disease or any autoimmune disease in the family. He consumes a mixed diet, had poor appetite for around last 2 months, bladder normal, no history of alcohol or tobacco consumption in any form. Summarizing my history, my patient is a 58-year-old diabetic hypertensive, 3 years post-renal transplant with insidious onset chronic diarrhea, likely large bowel diarrhea associated with weight loss and easy fatigability, showing poor response to IV antibiotics and discontinuation of MMF.
I will hold here, sir.
Yes.
Pooja, what kind of diarrhea are we talking about? Is it a large bowel diarrhea or it's a small bowel diarrhea? You've written
So
large
likely
bowel
large
diarrhea.
bowel diarrhea. Yes, sir. He
Okay, tell me the
says
characteristics of large bowel versus small bowel
small
diarrhea.
volume.
No, my question is
Sir,
very clear. You describe the difference between small bowel diarrhea and large bowel diarrhea.
okay, sir. Sir, large bowel diarrhea usually is of small quantity and semi-solid in consistency, whereas small bowel diarrhea has a watery consistency, large volume diarrhea. Also, large bowel diarrhea can be associated with symptoms of tenesmus, which is usually absent in small bowel diarrhea. Small bowel diarrhea usually has may or may not have crampy abdominal pain.
Okay. Weight loss is more common in small bowel diarrhea or large bowel diarrhea?
So small bowel diarrhea.
So you have mentioned large bowel diarrhea. Well, now, according to the history, it works out to be somewhere it's just a small bowel diarrhea. So why have you pinned that it as large bowel diarrhea?
So as he had semi-solid to
Weight
watery
loss?
consistency, he did not have
See,
large
he's got weight loss.
volume
The
stools.
volume is okay. It's not a very but the large volume. The frequency is how much is the frequency?
So 4 to 5 episodes
4 to
per
5
day.
episodes. Okay. So this fits into small bowel diarrhea rather than a large bowel diarrhea. So what is your differential diagnosis of this all the symptomology?
Sir, he has chronic diarrhea. Our duration of diarrhea is 2 months of chronic diarrhea. Since he's post-transplant, I would like to keep both infective and non-infective causes as my differentials. Non-infective causes being drug-induced, mainly drug-induced, or we still cannot rule out malignancy in keeping in mind that he had a history of weight loss. In among the infective causes, chronic diarrhea, I would first keep partially treated parasitic infections in the form of Giardiasis, Cryptosporidium, or viral infections like chronic norovirus infection, CMV, colitis. And tuberculosis also cannot be ruled out at this stage.
Tuberculosis causing a diarrhea.
Yes, sir, very unlikely,
Pretty
but then
unusual.
history of weight loss, yes, sir.
Okay.
History
So
of
we'll go to first. You said the first differential diagnosis drug-induced diarrhea. So what all
yes, sir.
drugs are indicated in diarrhea in this patient?
Sir, he was on MMF and on stopping MMF 1 month ago, he had partial relief of symptoms. So MMF is one of the drugs that is involved, but he continued to have diarrhea. So the next drug can be tacrolimus. Tacrolimus itself can also cause diarrhea. Non-immunosuppressive medications can also cause diarrhea. Like he is taking amlodipine. CCBs are also known to cause diarrhea. In this patient, other than that, none of his other drugs are.
What about he's a
He was
diabetic?
not on any. Though he's diabetic, he was not on any metformin. Sorry, sir, he was not on metformin, sir. He was only on insulin.
Could it be
So if he
autonomic
was on
neuropathy?
metformin, that could have been. Yes, sir.
Could it be autonomic neuropathy?
Yes, sir. It can be
So you should
long-standing
keep it in your
diabetes.
differential diagnosis.
Yes, sir.
Okay. Tell me the causes of infective diarrhea.
Sir, infective diarrhea can be bacterial, viral, parasitic, and tubercular. In bacterial, Campylobacter can cause diarrhea, and Clostridium difficile infection can cause diarrhea. He has also had history of multiple antibiotics usage, but that was for diarrhea. So these symptoms started before antibiotic use. Parasitic infections in the form of Giardiasis and Cryptosporidium.
Name more bacterial infections which are more common than Campylobacter jejuni.
Okay, E. coli, enteropathogenic E. coli and enterohemorrhagic E. coli can cause diarrhea. Salmonella, Aeromonas species,
Very rare.
Shigella.
What about
Shigella. Shigella also.
Yersinia?
Yersinia pestis.
Okay. Now come to viral.
So viral infections, though most of the viruses cause acute presentation, acute diarrhea will be rotavirus, sapovirus, adenovirus, enteroviruses, and norovirus can cause both acute diarrhea and chronic diarrhea, and cytomegalovirus.
Okay. And what about parasites?
Parasites will be Giardia, Cryptosporidium,
Very good.
Microspora,
Isospora
Microspora, Isospora.
and Cyclospora
Yes, sir.
and Entamoeba.
Entamoeba is still, yes.
Okay. So you feel it's a infective diarrhea or it's a drug-induced diarrhea?
So at this point, it can be both. More likely infective, because one of the drugs that were probably leading to diarrhea in him, that is MMF, was already withheld, and that did not show any response in him. But the other drug, tacrolimus, is still ongoing, so it can still be drug-induced diarrhea, but I would keep an infective diarrhea.
Okay. Agarwal, sir?
Amit, Dr. Amit should continue. Dr. Amit,
Yes, sir.
please continue.
Pooja, goes to the please go to the differential diagnosis.
Sorry, sir.
Your final diagnosis and the differential, then you can go for the examination part. This is the clinical diagnosis you have made. So what is your first suspicion in this case? You are thinking of infectious or non-infectious?
First will be infectious, sir.
Why you are thinking of infectious?
Sir, he probably partially treated infection. He drug-induced, again, will be MMF or tacrolimus. After stopping MMF, he did not have any response to it.
Do you have any prior TAC level history? Have the doctor changed the drugs frequently for this patient in the past?
No, sir. He was on stable.
Does he remember
and he was
the
actually
levels?
on follow-up here till around 2020. After that, he was being managed at a local hospital. He was not able to come for follow-up, so he was being managed at a local hospital.
So you have some investigations, then you can maybe proceed further. Pooja?
Yes.
Yeah, examination and investigation. I think so.
Yes, sir. On general examination, patient appeared cachexic. He had pallor and bilateral pitting pedal edema. He was conscious oriented, had a BMI of 18.75, a pulse rate of 110 per minute, and a blood pressure of 110/50 in right arm supine position. He also had angular cheilitis. On systemic examination, per abdomen examination, abdomen was flat, umbilicus inverted, linear surgical scar over the right iliac fossa. On palpation, the abdomen was soft, but there was tenderness in the periumbilical and the left periumbilical region and the left iliac fossa. On auscultation, bowel sounds were exaggerated.
Okay.
Rest of the systemic examination was okay. There were no positive findings.
Did you check for peripheral neuropathy and autonomic function tests? The patient is diabetic. For all you say, it's all diabetes related.
Yes. So sensory examination I did was normal.
Autonomic function tests. See, that is one of the differential diagnoses. Diabetes induced. Okay. Autonomic dysfunction can cause diarrhea.
Yes.
So just because the topic is viral infections and kidney diseases, we should not keep our eyes closed to other common causes. Okay.
Yes, sir. I'll keep that in mind.
So,
should I go ahead with investigation?
Yes, please proceed.
Hey, Pooja,
Yes, sir.
go back to the diagnosis. You see, most of the time, transplant patient, it is always better to say the donor source in the diagnosis, and post-transplant with the wife has, I think wife was donor, na?
Yes, sir. Wife was donor. Yes, sir.
So post-transplant with wife as a donor, then you should mention what is basic disease. So post-transplant with
Okay,
wife
sir.
as a donor, basic disease being type 2 diabetes
Diabetic
mellitus.
kidney.
But if you go to your presentation in the history, you were saying diabetic kidney disease. Now, what do you mean by diabetic kidney disease?
Sir, he had long-standing diabetes and was detected CKD in 2016. And he was told to have diabetic kidney disease.
No, I'm asking that if I say a patient has diabetic nephropathy and you say diabetic kidney disease, is those two terms have got same interpretation or it has got a different meaning?
No, sir, it has different interpretation. Diabetic kidney disease can be proteinuric or non-proteinuric kidney disease.
So diabetic kidney disease these are the only two subtype or a phenotype which are included in diabetic kidney disease?
Sir?
I'm saying you are saying diabetic kidney disease means whether patient may be proteinuric or non-proteinuric. So
Yes,
what
sir.
I'm saying that diabetic kidney disease, does it has only these two component while you are saying diabetic kidney disease? Or diabetic kidney disease has got other component also?
It is a spectrum of disease.
So once you are making basic disease as a diabetic kidney disease, which means that you should further clarify that what is in diabetic kidney disease. Otherwise, this become a broad diagnosis, which means that you are not sure whether it is diabetic nephropathy or no.
Okay,
So again, just coming to the diagnosis, we should mention post-transplant with donor source, then the basic disease, then hypertension is part of the illness, and then the chronic diarrhea should come later. And in transplant patient, you must include what is the status of the graft function in the diagnosis. Whether graft function is normal or you feel it is a graft dysfunction, because those are important components in making the diagnosis. Now you can go ahead further, please.
Okay, sir. Yeah. Sir, investigations on day 1 revealed a hemoglobin of 8.4, total leukocyte count of 6,400, and a platelet count of 3.27 lakh. His urea was 30 and creatinine was 1.9, sodium 126, potassium of 5.7, and a bicarb of 10. SGOT, SGPT were 52 and 43, and he had an albumin of 1.8. Stool analysis, which was sent,
For the urine
did not
examination?
show any.
What was the urine examination?
Urine examination, sir. I have
That
not
should come before
included
the
it,
stool
but
analysis.
okay, sir.
Especially when the albumin is 1.8.
Okay, sir.
Shall I proceed?
The stool analysis did not reveal any pus cells or occult blood, no ova or cysts. Stool for cryptosporidium was negative, and stool for Clostridium difficile was negative. Stool for PCR was also sent. His ultrasound abdomen showed thickening of the large bowel wall, and in view of this, CT abdomen with oral contrast was also done, which showed that the bowel loops were mildly prominent and fluid filled, and there was fat stranding in the mesentery and the retroperitoneum. His blood counts remained stable, and his creatinine was 2.1 on day 2. Sodium and potassium were 130 and 4.2, and bicarb was 9, albumin 1.92. Further investigations were sent, and vitamin B12 level was 960. Plasma CMV DNA PCR was also sent. His tacrolimus level came out to be 13.5, which was previously 6 in March 2022 and 8.1 in December 2021. He was kept on tacrolimus and steroid, and he was started on IV metronidazole, but he continued to have diarrhea. In view of chronic diarrhea with history of weight loss, we also did colonoscopy, which showed a normal terminal ileum, cecum, and colon. And in view of normal looking colonoscopy, multiple random biopsies were taken and was sent for histopathological examination. And meanwhile, the stool PCR that we had sent showed presence of Giardia lambia. He was continued on metronidazole. TTGA was negative, and he continued to have diarrhea. The histopathology that was done from the colonic biopsy showed an edematous colonic mucosa with a well-organized granular structure and mild chronic inflammatory infiltrate. However, because the patient was post-transplant, immunohistochemistry was also done, which showed presence of CMV antigens. By then, we also got the report of CMV DNA PCR, which was found to be 13,500 copies per ml. So my final diagnosis will be post-renal transplant of 2019 September with wife as donor and ATG induction, type 2 diabetes and hypertension, chronic infective diarrhea, with CMV colitis and giardiasis and acute graft dysfunction.
Okay, just hold on now. The tacrolimus levels were 13.5 as against the previous
Yes,
levels of 6 and 8.1.
Yes.
What? Why is it so? What do you think is the cause for high tacrolimus levels?
So diarrhea itself can increase tacrolimus levels.
How?
Mainly when we give tacrolimus orally, only around 20% is absorbed. This bioavailability is less, mainly because of three things. First will be because of the first pass metabolism. The other two things are what are important in a patient with diarrhea. First is P glycoprotein that is present in the gut mucosa. This helps in brings back the tacrolimus from the enterocyte back into the intestinal lumen and prevents absorption of the tacrolimus even in normal individuals. And in normal individuals, and also CYP34A is also present mainly in the liver but also in the gut mucosa. This helps in metabolism of the tacrolimus. So some amount of tacrolimus metabolism also occurs in the gut. So when a patient has diarrhea and these enterocytes are damaged or shred out, both the P glycoprotein and CYP34A in the gut are reduced. Due to this, there will be excess absorption and less metabolism of the tacrolimus, and hence there will be increase in tacrolimus.
Very good. And then there's another mechanism. What happens is there's a rapid ileal transit. Okay, because of the diarrhea, there's a rapid ileal transit which increases the tacrolimus delivery to the colon. Okay, and in the colon, lesser CYP3 or P glycoprotein activity. Okay, so there's an increased tacrolimus absorption from the colon. So there's a second reason why the tacrolimus levels are high. So what do you do if you find such high tacrolimus levels?
Sir, in such a patient, high tacrolimus levels itself can be causing diarrhea. There we reduce the dose, but we keep it on check. So this will require further modification of dose once the diarrhea settles.
Okay, what is another cause for increased tacrolimus levels in case of diarrhea? Apart from your enterocyte and tacrolimus, what happens in diarrhea? What happens to the intravascular volume? Is there any relation to intravascular volume, hemoconcentration, and tacrolimus levels?
Okay, sir.
question is there any
concentration will
between
lead to
the-
increased tacrolimus flow.
pardon?
Volume depletion will lead to hemoconcentration.
Yes.
That will be detected as high tacrolimus levels.
Okay. Okay, I have another question. Is tacrolimus dialyzable?
Not sure.
Not sure. It is not dialyzable because it's protein bound. Okay, my second question is, what is the cause of low albumin levels?
Sir, he had poor oral intake for quite some time, and chronic diarrhea itself can cause any chronic infection, and chronic diarrhea can cause malnutrition.
Is it a negative phase reactant?
Yes, sir.
Okay. So the patient had CMV. Patient had giardia.
Yes, sir.
So
Yes, sir.
do you feel it's a severe infection or it's a mild or moderate infection?
Sir, patient, considering his clinical condition, it will be because he had the graft dysfunction and malnutrition, I would consider it as severe infection.
It's a tissue invasive disease, as well as
Yes, sir,
the
tissue invasive
CMV
disease.
levels in the blood are high. So it's a severe
High.
disease. Any tissue invasive
Yes.
disease is a severe disease.
Yes, sir.
Okay. What were the gamma globulin levels in this patient?
Not.
So my question is, what is the relation of gamma globulinemia with the CMV?
Sir, hypogammaglobulinemia will predispose a patient to CMV.
Okay, very good. Why does it so?
Sir, for tackling an infection with CMV, both T cell mediated immunity and B cell immunity is required. CMV itself is an immunomodulatory virus.
Very good.
So, patient with hypogammaglobulinemia will be more predisposed to infections, especially CMV.
Okay.
Dr.
Especially
Manu,
CMV.
may I
Sir?
ask something?
Yes, sir.
Dr. Pooja, if I say that I want to get prothrombin time done in this patient, so
Yes.
what is the relevance of prothrombin time in this patient?
Prothrombin time, CMV can affect any organ.
Hey, you have missed some of the thing in the diagnosis.
Okay.
Can you go back to the investigation? Just no, back. No, some of the investigation was showing where the ALT was shown. Liver enzyme was shown. You see, now just hold on. Now this patient, post-transplant patient who has got his liver enzymes are normal or abnormal?
Sir, it is on the higher side, yes.
No, higher side, which means once we say higher side, we usually mean that it is still within the normal range, but on the upper side. But is this high or it is within the normal range? What is normal enzymes in post-transplant patient and a pre-transplant patient during dialysis?
In these patients, usually the AST ALT will be around between 12 to 20 range.
So practically
it is high on. Yeah.
Any liver enzyme which is on the higher range is abnormal.
Yes,
so
sir.
if I say of this patient or similar patient where the liver enzymes are abnormal, high,
Yes.
and the albumin is 1.8, what thing you want to exclude as a diagnosis, particularly once you said in the examination patient has cachexia?
Sir, CLD will be one thing that I would want to exclude.
So now you go back, what I asked, that if I am asking prothrombin time,
Yes,
what is the relevance of the prothrombin time in this patient?
my in considering one possibility of CLD, it will be increased.
It will be increased. So that is one of the synthetic function, because increased liver enzyme, low albumin, and that what Dr. Manu was asking the urine examination. If patient doesn't have a significant proteinuria, then we must seriously consider chronic liver disease, although he has got 2-month history of a diarrhea. But with the history of the way you presented history of diarrhea, that looks little less likely to produce cachexia and albumin of 1.8.
Yes.
And tell me, what is unusual in this patient as far as CMV infection is concerned?
Sir, he does not have any history of fever, no pancytopenia in his in his blood reports.
No, but tell me then, is the pancytopenia is a very common manifestation and seen in all patients, so that you
No,
can
sir,
exclude the CMV if there is
CMV
no
syndrome, then CMV syndrome can present with fever, malaise, and cytopenias.
Pooja, if a person has got CMV colitis,
Yes, sir.
is it common to have CMV antigenemia?
So patients may or may not have CMV in blood when they have a tissue invasive disease. They may or may not have CMV in blood.
Okay, that is one. Tell me another unusual thing for CMV in this patient. Okay, let me ask direct question. What is the timeline of CMV in post-transplant patient?
Okay, sir. Usually, it occurs between around 3 months post transplant. That is between 1 to 6 months after transplant. And if a patient is already receiving prophylaxis, it will occur usually around 3 months post after stopping the prophylaxis.
So one thing which you missed in giving information, that up to what period prophylaxis of CMV was given in this patient. That is important. Plus he was operated on 2019 and
Yes, sir, this
there is 2-month history.
is
So which means
late,
1.5
very
years
late
after.
presentation.
So he is a late
Yes,
CMV.
sir.
So then the next question comes, what is difference between conventional or early CMV versus late CMV?
Sir, usually late CMV will present after around 3 to 6 months after stopping the prophylaxis, and it is usually more commonly tissue invasive disease, and even in tissue invasive disease it is more commonly GI manifestation, and more severe forms can be pneumonia.
So GI manifestation is actually very common, and in late CMV often we may not find viremia, and it is the histology of gastrointestinal tract which picks up the diagnosis.
Yes, sir.
Okay.
Pooja, it is important, as was being discussed, that many times when you ask the gastroenterologist to do colonoscopy in such patients, and as you said that the biopsies were taken, many times many gastroenterologists, when they look at the colon and he found that this colon was looking good, they are reluctant to take biopsy. So it's very important, especially when you are suspecting that in a post-transplant period, a late cytomegalovirus disease, it's important to take biopsies. So many times as a nephrologist, it's very, very important when you send these patients, the biopsies, the colonoscopies or endoscopies might look normal, but tell your gastroenterologist to take biopsies. Unless you take biopsies, inform your histopathologist also that you're considering cytomegalovirus. So they must put a stain for cytomegalovirus and look for cytomegalovirus inclusion bodies on histology. So it's extremely important. Otherwise, this could be missed. If you were lucky that this CMV antigen was present and on PCR was positive, but many patients will have PCR negative. with this invasive CMV. So diagnosis is high index of suspicion. You will otherwise miss these diagnoses. So very, very important for the nephrologist, because he's the only one he or she is the only one who knows that this can happen in patients with transplant. And important to convince your gastroenterologist. Many times they refuse to do biopsies.
Yes.
I think Pooja, you can tell us how did you manage him now? Because of paucity of time, you can
Yes,
go ahead with the
we,
management.
I will just add one more thing, Pooja, for any chronic diarrhea in post-transplant, just keep IPSID also as one of the differential diagnosis,
Yeah.
which is also picked up by the biopsy.
okay, sir.
Sir,
Okay,
let me
go
ask
ahead.
two very practical questions, sir. Very important, sir. First is, Pooja, in what subset of the patients are you going to give a prophylaxis in a post-transplant scenario? That's the first
Sir,
question.
yes. Sir, prophylaxis is, there are types of, for prevention, there are two types. Either you give a universal prophylaxis or a preemptive therapy. Universal
My question is
prophylaxis.
prophylaxis. In
Yes,
what
sir.
subset of patients are you going to give prophylaxis?
Sir, in patients with donor positive status and recipient seronegative status, we have to give prophylaxis. In
Duration?
patients who are,
In this subset duration?
sir, up to 6 months.
Very good. Next.
Then patients who are receiving lymphocyte depleting agents like ATG, we have to give prophylaxis.
Okay.
Again, between 3 to 6 months, either 3 months or up to 6 months.
Usually 3 months. Okay, 100 days.
Yes.
Okay. Next. Would you like to use it in an avian compatible transplant who received rituximab?
Yes, sir. Even in
Or
patients,
they receive
yes, sir.
plasmapheresis of immune adsorption columns?
Yes, sir. It would be
If yes,
preferable
why
to give.
so?
Sir,
Why?
they are again hypogammaglobulinemia.
Very good. Now, my second question is, what is the threshold of your treatment for CMV? The levels in CMV DNA PCR levels, what is your threshold? What do the studies say? In kidney transplant patients, at what level are you going to start treating with valganciclovir or ganciclovir? Or you're just going to manage with reduction in immunosuppression? Suppose you have
So
a
there
patient
is
coming with 1,000 copies.
the guideline, there is no specific cutoff from. Yes, sir.
What do the studies show?
Sir, according to the consensus guidelines, there is no specific cutoff as such.
Okay. They say that around 2520 international units per ml is the threshold for treating. But in case the patient is D plus R minus, even 1500 international units per ml should be taken as a threshold for treating. Or else you can just manage the patient with reduction in immunosuppression. That's what most of the studies have shown.
Okay.
So we may proceed, sir.
Pooja, can you go to the treatment because we have got a second case. Otherwise,
Sir, we manage this patient with IV ganciclovir. We gave it for a period of 14 days, and the repeat CMV DNA was not detectable, and patient was also started on oral valganciclovir after completion of 14 days of IV ganciclovir.
So the question is, when do you convert the patient from IV to oral?
Sir, both oral and oral valganciclovir and IV ganciclovir are equally effective. So if a patient has a severe disease only and is not able to tolerate medication orally, only then we will go ahead with IV ganciclovir. At any point of time, the patient starts taking orally, we can switch over to valganciclovir.
Okay. And suppose there's a pediatric patient who presents with CMV viremia. How do you calculate the dose of valganciclovir or ganciclovir?
Ganciclovir 5 mg per kg body weight. Sir.
In pediatric population, we generally go by body surface area. And we use Schwartz formula for calculating the creatinine clearance. And in adults, the dosage
Okay.
is based on EGFR or creatinine clearance.
Okay.
I'm asking you a question. That 5 milligram per kg body
No
weight,
modification.
5 milligram per kg body weight, that's based on a creatinine clearance or it's EGFR?
Creatinine clearance.
By using which formula?
So, CKD
No,
in adults or in pediatrics?
formula. We do
So
not use CKD API for calculating drug dosages. It's only CG formula which is used. And in pediatric population, we use the body surface area and then Schwartz formula.
Schwartz formula, yes.
Okay.
Okay, sir.
So finally, Pooja, what happened to the after treatment? What happened to serum creatinine?
Sir, he was discharged with a creatinine of 1.7 and on IV ganciclovir of 14 days duration, and then he was switched over to oral valganciclovir. His peak creatinine was 2.1, sir. He was discharged on a creatinine of 1.7.
No.
How long do you treat it? How long do you treat?
Sir, 2 weeks of induction dose, and then secondary prophylaxis may or may not be given. According to the guidelines, secondary prophylaxis may not be indicated, but we usually give secondary prophylaxis.
For how long?
If
3
a
months.
person is resistant to ganciclovir, no
Yes.
response.
So, other drugs that can be used are foscarnet and cidofovir, with or without CMV immunoglobulin, which is not in the guideline as such, but it can be used.
Would you like to convert to mTOR inhibitors?
Okay.
They have some anti-CMV properties.
Yes, sir. Okay.
So after you're treated, what happens to mycophenolate mofetil and all? So what do you do with the immunosuppression?
Sir, we keep it at a lower level. We can restart at a lower level.
What stage would you restart after you treated it immediately? You want to do something or wait? Or
Sir, we would wait for at least 2 weeks after a negative CMV DNA PCR. And then we can restart at a lower dose, because presence of CMV itself is showing us that patient is severely immunocompromised.
yeah, so if he is immunocompromised, then, and this has happened in the late period of his course in the transplant period, it's not something very early, 2.5 years after the transplantation. There wasn't any episode of rejection. He wasn't treated with any anti-rejection treatment. So therefore, it was an all the immunosuppression was higher for him.
Yes.
So do you think that this will again predispose him to similar kind of infections and maybe a relapse of cytomegalovirus? So
we have to keep the immunosuppression at a lower level.
So how do you do that? By lower level, you are adding another, you giving him again two tablets of mycophenolate mofetil. So how do you reduce it? He was already on a maintenance dose of tacrolimus. He is back on mycophenolate mofetil. So he's back on the same thing. Why not continue 2 drugs only?
We can continue dual immunosuppression.
So would you? Yeah, this is a kind of a patient where I personally would probably consider that 2-drug immunosuppression, and there are many protocols worldwide in these kind of patients, and some patients, some sort of centers use single drug, tacrolimus alone, but we would want small dose of steroids in our patients. One, that it is cheaper, and the other is that we're not very sure about sometimes the patients don't follow up that closely. You need to follow up these patients closely once you on dual drugs or single drugs. So follow-up needs to be good, and you need to keep a watch on the donor-specific antibodies, and you can do a screen for donor-specific antibodies. And if they become positive, You could do it every 6 monthly, and if they become positive, then one might have to reintroduce this if the donor-specific antibody become positive. Otherwise, dual immunosuppression may be okay in many of these patients. Okay, I think we should stop probably
I
here
think,
and then.
the last, I think Dr. Amit has been the treating physician. Any comment from his side?
Yes, sir. So this patient, because he was obviously lost to follow-up, we couldn't track his immunosuppression levels and the immunosuppressor doses he was getting. And the way they present with cachexia, weight loss, long-term diarrhea, CMV infection, it's wise to, so there are 3 options, as sir said. Either we could stop this third immunosuppression, continue with dual immunosuppression, or we switch from MMF to mTOR inhibitors when the patient becomes negative, or we can do that right way also, or we can downgrade from MMF to azathioprine. So that's the way that we keep a watch on the patient, his tacrolimus levels to be maintained. Once you are on dual immunosuppression, we have to see the levels are at right level so that they don't develop in future the late rejections episodes. And yes, absolutely. Surveillance post CMV disease, once the patient also needs surveillance later on also, they might relapse, because it's the overall immunosuppression condition that we have to understand. So most of the times, even if we treat the patient with IV or oral valganciclovir, we keep on giving secondary prophylaxis for a few months and also keep in surveillance once it is stopped. So every 6 months, you can keep a surveillance of the patient. They might relapse after some time.
Dr. Amit, his creatinine has risen from 1 to 1.7. Would you like to do a biopsy? Why the creatinine is stuck at 1.7 now? Is it an effect of
So this is
tacrolimus?
on the follow-up. On the follow-up, if he stays, because he came with us in a dehydrated state, chronic diarrhea and all. So once his disease gets stabilized and his still graft function is deranged, we'll like to do a biopsy to look for rejection. That should be done.
Thank you very much. I think interesting case, some interesting features which are uncommon and well discussed. We will go to the second case because of paucity of time. I'll request Dr. Gaurav to start the case, finish it with the investigation, then we start the discussion. Dr. Gaurav Singh.
Start, please.
Just a second, sir. I'm not able to view my. Next slide, please. My case is 40-year-old serving soldier, resident of Haryana, educated till 12th standard, informant is self and reliability is fair. Next slide. He had history of hypertension in 2014, known case of chronic kidney disease since March 2018, initiated on hemodialysis since June 2019. The case of kidney transplant recipient in March 2021 and on our regular follow-up since then. He presented to our OPD in month of July 2022 with complaints of anorexia since 15 days and joint pains lasting for 10 days. Next slide. I would now like to go back to my history, which dates back to June 2014, when he was asymptomatic and was found to have high blood pressures during his routine medical evaluation in Army. No medications were given. He was advised salt restrictions, and all investigations as reported by the patients were normal that time. From 2014 till 2018, he remained asymptomatic. His routine investigation in month of March 2018 showed serum creatinine of 2.1 milligrams per deciliter with urine protein of 2+ and 24-hour urine protein of 2.8 grams per day. He was subjected to a kidney biopsy in our hospital that time, and it was suggestive of a diffuse global glomerulosclerosis type of picture. And so he was started on conservative management for same. Next slide. He was advised conservative management. He was advised vaccination, but he only took 2 doses of hepatitis B. He remained asymptomatic after that. In January 2019, he developed a episode of febrile illness. That time, his creatinine jumped to 7.9 milligrams per deciliter. Along with, he was having hyperkalemia that time. So he was given 5 sessions of hemodialysis through a right internal jugular catheter, uncuffed. After that, following 5 sessions, his dialysis was stopped since he was maintaining a creatinine of around 4.9 to 5 milligrams per deciliter. He was advised AV fistula formation, which was constructed on 22nd of March 2019, which was his vascular access till he was transplanted. Next slide. In June 2019, then he had history of anorexia, nausea, vomiting, reduced urine output of 15 days duration. The investigations that were done suggested hemoglobin of 9 and creatinine jumped up to 8 milligrams per deciliter. He was again admitted to the hospital for initiation of hemodialysis. This time, the investigations that were carried showed HBsAg positive and hepatitis anti-HCV also positive. He was evaluated and no liver dysfunction was found. The synthetic tests of the liver were carried out. Those were normal. Further, for his evaluation of hepatitis B and C, HBV DNA and HCV RNA PCR studies were done. Both were suggestive of more than 1 lakh copies as recalled by the patient. And a genotyping for HCV was also done that time, which suggested genotype 1B. Next slide. Next slide, please. So for hepatitis B, he was started on tablet entecavir 0.5 mg after dialysis sessions once weekly. He was also started on direct acting antiviral agents in form of sofosbuvir 400 mg and lepidasiran 90 milligrams OD for 12 weeks. Patient responded in 6 weeks, and the repeat tests that were done, the DNA-based tests, were both negative. He was counseled for renal transplant, proposed YFS duration. His total dialysis vintage was around 21 months, nil blood transfusions, and approximate dialysis sessions were around 220 before we took him for transplant. Next slide. He underwent a kidney transplant on 21st of March 2021 with wife as the donor. He received basiliximab induction, followed by maintenance immunosuppression was TAC, MMF, and prednisolone. He was a 5/6 mismatch with his wife, and flow PRA that was done was 3% and 1% respectively. He attained the post-transplant period was uneventful. He attained a nadir serum creatinine of 0.9 milligram per deciliter on 5th day post-op and was asymptomatic and discharged in stable condition. However, in June 2021, approximately 3 months post-transplant, he developed a mild rise in serum creatinine. His baseline used to be around 0.9. He developed acute graft dysfunction. Creatinine raised up till 1.2 milligrams per deciliter. That time he was evaluated, and evaluation showed the BKV DNA PCR that was done suggested 9,000 copies per ml. His MMF was reduced to 250 mg BD and then stopped after 1 week, with repeated BKV tests being done on regular basis. In next 2 months, the BKV became undetectable in bloods, and his creatinine settled to 1 milligrams per deciliter. So MMF was reintroduced. He was asymptomatic thereafter till October 2022. Next slide. Now I would like to present my history of present illness from July 2022, that he had history of anorexia for 15 days, which was not associated with complaints of vomiting or fever, no history of diarrhea or weight loss. He also had complaints of joint pain since 10 days, which was on and off, mild in intensity, not associated with any rash or deformity, no diurnal variation, not associated with fever. It involved both small and large joints. It was intermittent. There was no fleeting type of joint pains or deformities, no restriction of range of motion over the joints, no signs of inflammation over the joints, no early morning stiffness or stiffness of the axial skeleton. Next slide. My negative history included no history of chest pain, breathlessness, syncope or palpitations, no history of decreased urine output, frothuria, graveluria, hematuria or flank pain, no history to suggest a UTI or pain at the graft site, no history of abdominal swelling, pain abdomen, vomiting, yellowish discoloration of eyes and urine, melena or hematemesis, no history to suggest a connective tissue disorder, no history of tremors, excessive sweating, cold sensations, polyuria or polydipsia. Next slide. There was no history of weight loss or evening rise of temperature, no history of prolonged hospitalization or NSAID abuse or history of alternative medications. There was no history of recurrent blood transfusions or IV drug abuse or high-risk sexual behavior, no history of use of infected needles. He denies any history of hepatitis or any LFT abnormalities to the spouse while she was being worked up for transplant. Past history was not significant. Personal history, no addictions. He was vegetarian by diet, normal bowel and bladder habits, no history of high-risk behavior. Family history is not significant. Patient was on tacrolimus 3 milligrams BD, MMF 500 milligrams BD, prednisolone 5 milligrams OD, and entecavir 0.5 milligrams OD. After history, my summary is 40-year-old male, a case of chronic glomerulonephritis related CKD, managed on maintenance hemodialysis, developed hepatitis B and C co-infection while on HD, was treated with antivirals and became HBV DNA and HCV RNA PCR negative. Then he underwent successful renal transplant with wife as donor, attaining good renal function, developed post-transplant BKV infection, managed with reduction in immunosuppression, and now presented with anorexia and joint pains of 15 days duration. Next slide.
Yeah.
Coming to the examination part, his weight is 62 kgs and BMI of 21.3 kg per meter square. Pulse rate
What
of
was your differential diagnosis?
Sir, my
you can give us a
sir. At the end of history,
provisional diagnosis before you go for examination. We want
yes,
a.
Sir, my differential diagnosis at the end of history is, firstly, since there is a history of anorexia and joint pains, probably some acute infective etiology is my first diagnosis.
How many joints were involved?
Sir, he complained of non-specific type of joint pain, sir, involving both small and large joints, sir. It involved bilateral knee joints. Then it involved the first metacarpal joint. Like this, sir, he also complained of on and off shoulder pains as well, sir.
So it's basically polyarthralgia. And you
Yes.
suspect infective, basically, are you suspecting bacterial or viral?
Sir, most likely some viral arthralgias, because there was no associated deformity of the joint, or there was no local range of motion restrictions, or local septic type of joint was not there, sir.
There was no swelling, only there was pain, joint pains.
Sir?
Only there are joint pains, but no no swelling in the joint.
No swelling in the joint, sir. The on visual on inspection also, sir, there were no signs of no redness or inflammation or raised temperature over the joint, sir, and no deformities, and range of motion was also not affected, sir.
You can go for the examination and then.
Coming to the examination part, BMI of 21.3 kg per meter square, pulse rate of 88 per minute, blood pressure of 138 by 88 millimeters of mercury measured in right arm in sitting position. His left radiocephalic AV fistula thrill is present. General physical examination was normal. No stigmata of chronic liver disease like pulmonerrhythmia, spider nevi, gynecomastia, loss of secondary sexual characters, half and half nail, thin brittle hairs were seen. Next slide. Systemic examination, abdomen had a normal look. There was a well-healed oblique scar in the right iliac fossa, measuring 14 centimeters. No sinuses or peristaltic movement was seen. Renal allograft was firm and non-tender. There was no hepatosplenomegaly, no other palpable lump, no ascites. Renal allograft bruit was heard in right iliac fossa. His genitals were normal, no hernia. CNS examination was unremarkable. CVS S1, S2 heard. Left ventricular S4 was heard. No murmurs. Respiratory examination was normal. Investigations revealed a normal CBC with hemoglobin of 13, TLC of 9,000 per millimeters cube, creatinine of 1, blood urine nitrogen 15, sodium 140, potassium 3.9, calcium 9, phosphorus 3.2, serum bilirubin 0.9, AST 183, ALT 149, GGT 30, ALP 130, urine REME was normal, urine routine was normal, and urine culture was sterile. Next slide. USG abdomen suggested 16 centimeter liver with grade 1 fatty changes. No splenomegaly. Renal allograft was normal with normal echogenicity and CMD. Bilateral native kidneys were contracted. His Doppler imaging of renal vessels was normal. BKV DNA PCR as well as CMV DNA PCR were target not detected. Next slide. Coming to his other investigations, his hepatitis A, hepatitis antigen.
On this examination based, do you want to add anything to your differential diagnosis?
Sir, my examination was non-contributory, sir. So my differential diagnosis at this point was the same, sir.
Still, you are thinking of that.
Yes, sir.
You're still with hepatomegaly. Don't you think that could be due to chronic infections, or there is reactivation of the infection? Especially patient has been hepatitis C and B positive in the past.
Yes, sir. But other till my history and examination, sir, I could not find any other features of hepatitis. There was no pallor, sir, and there were no other signs also for to suggest hepatitis causing joint pains, sir.
Okay.
So in other investigations were hepatitis B surface antigen positive, HBeAg negative, anti-HBe negative, anti-HBc IgG was positive, hepatitis B DNA PCR was target not detected, anti-HCV was positive, and HCV RNA PCR suggested 11 into 10⁶ international units per ml. Genotyping was done, which was same as before, 1B. His HIV status was negative. He was further subjected to upper GI endoscopy, which did not reveal any features of portal hypertension. His fibroscan was done, which suggested normal elasticity, and CDFI of portal axis was also normal. Patient was then started on sofosbuvir 400 milligrams plus velpatasvir 100 milligrams for 12 weeks, and he was continued on entecavir 0.5 milligrams. He was further put on follow-up, and he attained viral remission within 4 weeks. My diagnosis at this end junction will be case of chronic kidney disease, chronic glomerulonephritis, pre-transplant hepatitis B and C infection treated with antivirals, transplanted in March 2021, which was uneventful. Post-transplant BKV, which responded to responded to immunosuppression reduction, and recurrence of hepatitis C infection in post-transplant period without any associated liver decompensation, presently on directly acting antiviral agents, as well as maintenance with entecavir for hepatitis B status.
What about the joint?
Sir, the joint pains that were there were non-specific, and they responded to paracetamol. And after initiation of therapy, sir, the joint pain subsided.
Could it be due to any reason related to hepatitis C, this joint infection, joint pain?
Sir, hepatitis C is known, the prodromic phase of hepatitis C, it is known to be associated with joint pains, non-specific type.
Any other way they can do?
Sir, apart from hepatitis C,
No, hepatitis C, can it be some systemic involvement that they can do joint
yes,
pain?
sir. Sir, hepatitis C can lead to by immune complex mediated mechanisms. The immune complexes can get lodged in the joints, and then they can elicit immune response and
What do
cause
you call it, Gaurav? There's a specific
cryoglobulinemia,
term
sir.
for it.
Cryoglobulinemia, sir.
Mixed cryoglobulinemia.
Mixed cryoglobulinemia.
Which type of mixed cryoglobulinemia the CV elicits?
Sir, most commonly it is type 2, but it can be associated with type 3 as well, sir.
Can it cause joint pain without causing mixed cryoglobulinemia?
Yes, sir. Hepatitis C, as such, sir, due to the direct cytopathic effects of the virus, sir, it can cause joint pains. But they are, in majority of the cases, they are non-deforming.
Yes, even SCV vasculitis, can present as a vasculitis kind of joint pain. So this patient, the first one, just I wanted to note that it's not lipid aspirate, it's lipid aspirate that the patient has first. So one thing is, if somebody comes for you for a kidney transplant and has found to be SCV positive, a patient on dialysis, what is your approach? Do you go for workup or you start DAs and then go for workup? How do you approach the patient?
Sir, if a patient comes to me with hepatitis C positive, firstly, I will check his RNA levels to see the viral load. Secondly, sir, I would check the patient's liver profile, whether it is a case of whether the liver is affected to a stage of cirrhosis, or the cirrhosis stage has not reached. This will help in making my treatment decisions and my plan. So if a patient is willing for transplant, and if transplant is contemplated within the next 24 weeks, then I would not like to start on therapy, sir. I would go ahead with the transplant and start on direct acting antivirals after transplant. But if the contemplated delay is more than 24 weeks, sir, then I would like to start my patient on a course of DAAs for 12 weeks and then wait for another 12 weeks to attain the sustained viral remission and then go ahead with the transplant.
Is it 24 weeks or 8 weeks? So nowadays, if you want to start in a delay the transplant, they give us a go ahead with 8 weeks.
Sir, I am putting KDIGO 2018 consensus guidelines on hepatitis C, sir. They have mentioned 24 weeks, sir.
Okay. And for the patient, if he is an SCV positive and you want to go for a transplant, does it change your any thought process of medication, say like immunosuppression or induction? Or does it affect your decisions, or you go ahead as usual for other patients also?
Yes, sir. Sir, the anti-metabolites do not have any interaction with the DAAs. Prednisone also doesn't have interactions. So if we are anticipating transplant, so we can after genotyping, there is a pan genotype drug, grazoprevir plus albuterol, sir, which do not have any significant interactions with the tacrolimus. But if we are planning to give cyclosporin, then we should be cautious, because cyclosporin is known to increase the levels of this DAAs by around 25 to 30%. So it is better if we use the tacrolimus as CNI and not cyclosporin. Otherwise, other two immunosuppression can be kept as same, sir.
So in the eras of there was no DAs, there was only interference, and when they used to start giving interference before transplant. So there was a question of choice between tacrolimus and cyclosporin. Do you have any idea the cyclosporin effect on SCV in vitro or in vivo? Does it differ between cyclosporin and tacrolimus on the hepatitis C? Is there any difference how they affect?
I am not aware, sir.
Yeah, if you go back, few years go back, you will see that patient with SCV is preferentially given cyclosporin because they have some in vitro activity against hepatitis C, so they are preferred. But in vivo, it has not shown to give any antiviral. So tacrolimus is as because most of these physicians are comfortable giving tacrolimus, they keep on giving. And now in eras of DAs, it doesn't make a difference between choosing between the immunosuppression. Yes, for induction, if you are going with a patient with a CVR and a high CVM20, yes, probably you will not prefer to give thymoglobulin induction. These are similar to will be more preferable in these cases or no induction. And
If
so,
I may add,
yeah.
Gaurav, there's an interaction between the CNIs and DAs. There's a certain group of DAs which have an interaction with CNIs. They are those drugs which are used for HIV also,
Sir.
like ritonavir based or dasabivir. They have interaction.
Sir. Protease inhibitor
yes,
class of
they have
drugs.
interaction.
Sir.
Most of others do not have.
Sir.
A couple of questions from Gaurav. Why the SGOT-PT levels are below normal in CKD patients?
Sir, in CKD patients, especially who are on...
We normally take low level. Normally, if the level upper limit is 40, impossible in CKD patient, we go for level around 20.
Sir, there are in CKD patients, especially who are on hemodialysis, sir, the levels of these liver enzymes are less than the normal. The accepted levels for AST is 24, while the accepted level for ENT is 17.
Why?
Sir, one reason is the pyridoxine deficiency, sir. Pyridoxal phosphate is cofactor for both of these enzymes, sir. In CKD patients, due to nutritional deficiencies as well as removal of pyridoxal phosphate during dialysis, the synthesis of these enzymes is less.
Good. Your patient received 2 doses of hepatitis B vaccine.
Sir.
You said he did not receive after that. If he receives full 4 doses, what is the seroconversion?
Sir, the seroconversion rate after 4 doses approaches around more than 95%, sir.
No, that is a normal healthy population.
Sir.
We're talking about CKD population.
Sir, in CKD, if we are using the recommended dose in CKD, that is double the usual dose, sir, then the seroconversion rates are more than 90%, sir.
No, I don't agree with you. I think we will take opinion of other experts also. I think the conversion rate, though it all depends at what stage of CKD you are vaccinating a person, earlier the better, but generally it is 50% or less than 50%. That is why previously we all used to give adjuvants, GMCSF, GCSF, whatever maneuvers, but the response rate was around 50% or less than 50%. Rather, in dialysis population, we did a study, it was 30% only. So earlier the better, that is the lesser. Your patient, you gave him entecavir, and you said after 12 weeks or so, he became hepatitis B DNA negative.
Sir.
What is the reported response rate? Is it unusual or it is usual? Because normally you start treating patient with hepatitis B in CKD patient, the response possibly they never respond fully. And entecavir, you are continuing, that is why lifelong.
Sir.
So what is the response rate generally?
Sir.
That is for my information. You must have read the topic thoroughly now. Yeah.
Sir, according to me, sir, hepatitis B DNA can never be eradicated since it integrates with the host genome. So it is never possible to eradicate hepatitis B completely. What we can measure is the hepatitis B DNA levels, and like in this case, it has become a target not detected. But one point to mention here is that he is still hepatitis B surface antigen positive. So in CKD patients, as vis-a-vis the normal population, though the rates of HBV DNA being not detected, being detectable below the like being present below the detectable limit is similar, but the rates of hepatitis B surface antigen loss, which is the endpoint of therapy for hepatitis B, it is less in CKD patients. So in most of these patients, we have to continue entecavir lifelong. But in normal populations, after hepatitis B surface antigen loss, we can stop the drug.
Why you mean a person who is hepatitis C positive, why his outcome is inferior to person who is, let's say, non-HCV positive?
for transplant, sir?
Yeah, for transplant or CKD
Sir.
patient, we
Sir.
know that person who is HCV positive or
Sir.
HBV positive, they have got more than double the mortality risk.
Sir.
Likewise, in transplant, the risk is much higher. Why is so?
Sir, it is because hepatitis C has an independent effect on the kidneys for albuminuria, sir. It has been shown and well proven in the studies that even if we leave behind the kidney manifestations which hepatitis C is causing, it is independently associated with increased rates of albuminuria. That is one. Second, hepatitis C has also got association with NODAT, sir, which also increases the morbidity in the post-transplant period.
Anything with the cardiovascular system, any
Yes,
other
sir.
problems?
Sir, hepatitis C has also been independently associated with increased cardiovascular mortality, as well as due to its property of causing chronic lymphocyte activation. It is also associated with post-transplant lymphoproliferative disorders. All of these contribute to its increased morbidities in post-transplant phase, sir.
In your center, what is the incidence or prevalence of hepatitis B and C now?
Sir, presently in our hospital, sir, we are doing a nucleic acid testing for all patients on dialysis, sir. And in last 4 months, we have got and we have separate machines for hepatitis B and C. In last 4 months, sir, we have reported just 2 cases of hepatitis C. And
I'm talking about prevalence. If you have got 100 patients on dialysis, what percentage is having HCV positivity now?
Sir, it is less than 1%, sir.
Less than 1%. Okay. Okay. But do you need a separate machine for hepatitis C or just you are taking extra precautions?
For hepatitis B, we need separate machine, but
That's
for
all right.
hepatitis C, separate machine is not necessary, but still we have a machine in our dialysis
I
unit.
think Professor Sanjay Agarwal's and Professor Kher's comments, please.
No, I think Sanjay has been quiet. I don't know.
No,
Sanjay?
Dr. Varma was asking. So, Gaurav, there are certain things which were missing. Say, in terms of a hepatitis C, you make a statement that hepatitis C was clear. Actually, you should clearly mention that patient attained sustained virological response or not. Because clearing the virus immediately at the end of a therapy doesn't mean that the patient will have sustained virological response. Because the patient might not have sustained virological response, then in the post-transplant period, recurrence is fairly common. Otherwise, in nowadays with oral direct antiviral agent, if the patient has sustained virological response,
Sir.
relapse of infection is very, very uncommon.
Sir.
Second controversy, which although there is no clear-cut guideline, but at least we are following a significant number of a patient. You make a suggestion that if there is a waiting period of 24 weeks for the transplant, then you would like to wait for the transplant and will treat the patient after the transplant. Actually, if you see the timeline, if you start direct antiviral agent and do the serial monitoring every weekly, most of the patient, irrespective of the viral load, clears the virus by 7th or 10th day. So in fact, in our institute, we have got a huge number of a patient whom we don't wait. Say we start whenever the patient is found to be HCV positive, even
Right.
10 days before, if the patient is found to be positive, we start antiviral. For 10 days, do the transplant done, and the rest of the period in post-transplant period, we continue antiviral and complete the duration of therapy.
Sir.
Then, but whichever way the patient is treated, we must document that patient has got sustained virological response and not only the end of virological response.
Sir.
In patient of hepatitis B with entecavir, hepatitis B DNA clearance is 85 to 90%, but surface antigen clearance is only 10%. So ideally, if you interpret the literature, then person who has got hepatitis B DNA clear but surface antigen positive, they used to call them as a carrier in past. But nowadays it is very clearly mentioned that there is nothing like carrier state in hepatitis B infection, because hepatocyte has got, if we go for a biopsy and do in situ hybridization, then hepatitis B virus is found in hepatocytes. So that is why lifelong treatment is required in the patient. As you said that if surface antigen is also cleared, then you can stop, but that clearance of surface antigen is only 5 to 10%.
Sir.
Tell me question that in a living related transplant, if a living donor is found to be hepatitis C positive,
Sir.
and you have investigated patient was due for transplant,
Sir.
and just before the transplant, once you repeated, the donor was found to be HCV positive.
Sir.
Then what next?
Sir. Sir, earlier donor HCV positivity was considered as a contraindication to renal transplant, but nowadays, sir, because it was seen that if hepatitis C positive donors, the kidneys are taken and transplanted into HCV positive recipients, then
No, I am saying a recipient is negative.
Okay, sir.
Only donor is positive.
Sir, if donors are HCV positive and recipients are HCV negative, sir, then after obtaining high-risk consent from the recipient and after initiating direct-acting antivirals to the donor and after attaining the sustained viral remission, we can take him up for transplant.
And suppose the in same situation is in the diseased donor, that there is a diseased donor who is HCV positive, and obviously you can't treat that diseased donor.
Sir.
Then what?
Sir, then also we can take and start the recipient on DAAs in the early post-transplant period, sir.
Early post-transplant period means that you mean that you will not start on day one.
Sir, I don't know the exact days when we have to start it, but in the early post-transplant period only we have to start DAAs, sir.
Okay. Another, just because of the shortage of time, one more thing, that the hepatitis C positive patient actually in a pre-transplant period, if the patient is infective and with HCV infection, and you are assessing the patient immunological status, you many times you will find that patient, once HCV positive, has got flow cross match positive.
Sir.
Because HCV has got induction to B cell. So many times you will find that once you start antiviral drug and clear the virus, that antibody or panel-reactive antibody or flow cross match then becomes negative.
Sir.
So interpretation of a flow cross match and panel-reactive antibody vis-a-vis HCV infection should be kept in mind, that it may not be something which is very serious, because once the virus is clear, antibody also get clear in most of the patients.
Sir.
So
Dr. Agarwal, there is a question that your dialysis patient is HCV positive. You have started a DAA. After 4 weeks, he is negative.
Sir.
At what stage you would like to mix him with a normal dialysis population?
So what we follow, that 2 monthly HCV RNA is negative, then we shift to
because
the
some
normal
centers
side.
are doing 3 months, let the therapy be complete. But your suggestion is 2 HCV RNAs are negative, you can mix them.
Because with our study, we haven't found breakthrough infection in HCV. So if you are continuing therapy, full therapy, in between, it's very unlikely that he will have a breakthrough infection. So chances of spreading to other patient is very, very uncommon.
Okay. And you study the response rate to hepatitis B vaccine?
Hepatitis B vaccine, if we do say moderate stage 3 or stage 4, not at the end stage, then it is approximately 70% patients, 70 to 75% patient respond with full 4-dose, double dose immunization schedule.
Of course, if you are doing late, the response is pretty poor.
It decreases. In fact, even we are immunizing patient with the primary glomerular disease also, once the primary glomerular disease is diagnosed, they should be immunized because leaving minimal chain disease, most of the primary glomerular disease on the long term, there is the risk of going into chronicity.
Professor Kher, sir, your comments.
I think I would agree with, by and large, most comments that in our study, we found that actually if you immunize for hepatitis B stage 1 and 2 or 3, usually the response rates were somewhere around 80%. Stage 4 and 5 and on dialysis, the response rates ranged from 50% to about 60% or so. I think it was 57%. To be precise, stage 4, stage 5 disease, which was published long time back. And we, as you said, were using GM-CSF as the adjuvants to improve the seroconversion in patients with hepatitis B. Hepatitis C, I think we don't, we in our units have never isolated patients. We've used vigilance and universal precautions for hepatitis C, and our seroconversions, new seroconversions were very low, less than 2%, 1% or so. So by and large, we never isolated patients. But I agree that in high prevalence zones, probably, and Sanjay, given that.
One other question is, which method of testing should be adopted? Many times patients come to the dialysis center, they do a spot test for hepatitis B and C. What is the ideal, what is the minimum standard which should be followed? Professor Agarwal.
No, even CDC guidelines for infection prevention in hemodialysis suggest that the first time it is nucleic acid test which should be done.
Yeah.
So nowadays what we do, the first time we do nucleic acid test, and then because our infection, we follow isolation. So our infection rate, new infection is negligible, is 1 or 2%. So we, if any time in between a negative patient is found positive, then we, in that shift, whichever patient was being dialyzed, we do antigen test, this nucleic acid test of rest of the patient. One thing I would like to say for Gaurav, if you, although a usual recommendation statements are made that the guidelines doesn't suggest isolation, but if you compare the CDC guidelines, there are 2 guidelines published at 12-year interval, and the language of the recent guidelines changed. They clearly said that if the local unit is not able to prevent the HCV infection, there is a definite role of isolation. And if you go to other guidelines, Australian guidelines, and the language is little ambiguous. They don't make a statement that isolation is not required. So nowadays, this often is raised in social circle also. Say, ministry often asks from the expert that people go to the litigation also. So this is the issue which is at a different forum. So we most of the time say if the center is able to prevent if there is no new infection for the next 6 months, then there is no need of isolation. That unit can continue to dialyze. But any unit which is not able to prevent infection, there is a role of isolation.
Sir. Yeah, I think I would agree with that probably units which cannot prevent infections and where universal precautions are difficult to follow, and many units will have that in our country, and therefore guidelines should always be interpreted in relation to the local environment which is existing in that unit, irrespective of whether the guidelines accept or don't accept. It doesn't matter. Ultimately, what matters is how you treat your patients and how do you prevent infections. So it's important to follow your own guidelines in this kind of a situation. So I would go by those guidelines. But
so for the guidelines, if you see the current recent KDIGO published how to make the guidelines, there is a supplement on how to make the guidelines. So making a guidelines is, we often go and make a guidelines within a month or so. It's a huge process actually. Yeah. And a proper guidelines need really a very hard work.
Yeah, one is the guideline, but the guidelines have to be relevant to the local conditions.
Local
See,
environment.
basically, guidelines are evidence-based, and many times there isn't much evidence in the kind of the dialysis units we have. So usually they talk of ideal dialysis units. Then where are the ideal dialysis units in our country? So these are things which need to be looked at from that perspective. So I think I would probably interpret them with that kind of caution. And the other thing is that can all the guidelines be followed? And ultimately the guidelines will have to be followed to the extent that you can do these guidelines. Otherwise, these guidelines have no relevance.
I think it has been a very, very long topic. It is a long topic. And I think due justice has been done by examiners. I thank Professor Manu Dogra and Professor Mahapatra. They covered hepatitis B, C, we covered BKV and CMV. It's not possible to cover huge topic. There's a huge topic. And I thank Professor Sanjay Agarwal for his expert comments, and which are very valid. And as Professor Kher said, the guidelines are there, but you have to interpret in your own circumstances how you are going to do. Thank you both the students, Gaurav and Pooja. They did good job. I now hand over to Professor Kher for the final and concluding comment.
No, I think you said it all, and I think it was indeed very, very useful. And I think on a personal note itself also a lot of learning. And I think Sanjay is always, as usual, very erudite, large personal experience itself. And I think with this, I think we would sort of close the session. Thank all the students and the examiners, Dr. Manu Dogra as well as Amit. And I will now hand it over to Mr. Raja. Mr. Raja, I can see now he wasn't there, and maybe
sorry.
I think on behalf of Kern as well, we would like to thank you for providing the logistic support for these kind of activities. And I would thank Sanjay as well. Sanjay usually is rare to find you.
I was skeptical whether he will.
No, extremely thankful, because Sanjay provides the real personal experience to it.
It is because it is our friend circle. I mean, I had a terrible time in last 6 months. Lost my father and lost my wife's father.
So sorry.
And my brother is in ICU today for influenza H3 and 2 infection. So that is why I requested Professor Varma that I may not be, but touch wood, he has improved and shifted to the ward in the evening itself.
Okay, let's hope he gets home soon. And with this, we thank you as well as thank Micro Labs for that. And Mr. Raja, for you to close.
Yes, sir. I think it has been a very wonderful session, and I think the students community are quite getting excited about the entire program with the recent feedback we have tried to do in the ISM. So we actually thank the course directors for really helping us to put forward. And my sincere regards to Dr. Sanjay ji, despite all his personal commitment, he could make it up today. And Dr. Colonel Manu Dogra ji, thank you very much for coming over and sparing a valuable time, sir. And the students, Dr. Gaurav as well as Pooja. Thank you very much, all of you. And Dr. Amit Kumar Mahapatra ji also for having spared your time. So on this occasion, we take all the pleasure in wishing you all a happy New Year 2023. We hope that we are going to have an insightful and pleasant year all together, and we would be committed towards the academic learnings of the Nephrology team. Thank you very much once again, and have a great
Thank you.
Thank you. Happy New Year. Happy New Year to everybody.
Thank you, sir.
We had 62 students today.
Yes, sir.
62 participants. So both YouTube and this channel. Thank you very much.
Thank you.
All
Thank you,
the
sir.
goodbye.
Thank you.
Bye bye. Bye bye.
Bye.
Thank you, sir.
Thank you.